Hello guys, myself Yatan, and today we are going to discuss about pelvic inflammatory diseases. So first we will discuss about the definition. So what is PID? PID is a acute inflammation of the upper genital tracts that may include the uterus, that may include the oviducts, or it may include the ovaries. So what is the definition? It is acute inflammation of upper genital tract that include what things? Ovaries, oviduct, and uterus. In majority of cases, it is caused by the sexually transmitted pathogen like chlamydia and gonorrhea, and it may involve the neighboring organs and cause the inflammation of that particular organ. Like if it affects the oviduct, then we will call it as a salpingitis. If it affects the endometrium, then it is endometritis, and if it affects the peritoneum, then it is peritonitis. So it may cause tubo-ovarian abscess, and it may cause the perihepatitis. Sometimes it is known as Fitzhugh and Cutis syndrome. So it may involves neighboring organs like and causes their infection, that is salpingitis, endometritis, tubo-ovarian abscess, perihepatitis, that is Fitzhugh and Cutis syndrome. About this we will discuss about later. And what else? Peritonitis. So this is all we have in the definition. Now we will move to the risk factors. So what are the main risk factors of PID? It may be the age, it may be any addiction. So in this case, the PID generally affect the women of age group 15 to 25 years old, and who have multiple sexual partners, who has a history of dishing, and that women may be having like smoking history, or in case of IUD insertion. Like how IUD insertion leads to PID. In this case, if any woman comes to you and she's having chlamydia or gonorrhea infection, and in that case if you insert IUD, it may lead to the ascending infection to the pelvis and causes the PID. So what are the risk factors? Risk factors include age between 15 to 25 years, multiple sexual partners, prior history of PID, IUD insertion and smoking. So these are the main risk factors that cause the PID. Now we will discuss about the clinical signs. So what are the clinical signs you will see? PID can be silent, like if there is a, it can be asymptomatic if there is a no particular symptoms, maybe it is in an initial stage. So what are the main signs? Generally, the patient with PID is present with the pelvic or abdominal pain. The pain can be crampy, it can be stabby, it can be unilateral or bilateral, or maybe pain is absent. In that case, if the pain is not present, that condition we call as silent PID. So, what is the most important or most commonest sign is lower pelvic or abdominal pain. It can be stabby. This is the characteristic of pain. Stabby, crampy, can be unilateral, or it can be bilateral. This is the one of the most commonest sign you will see. Other is vaginal discharge. And next is abnormal bleeding, abnormal odor, right upper quadrant pain, that is perihepatitis, and this is all we have in this case. So जिस पेशेंट में PID होती है उसमें you can see there is a right upper quadrant pain. Why there is right upper quadrant pain? हमने बोला था कि PID नेबरिंग ऑर्गन्स की भी इन्फेक्शन कर सकती है. तो जो PID है may ascends to the liver and it causes the perihepatitis. In this case the parenchyma of the liver is not involved. इसमें क्या होगा, पेशेंट बोलेगा कि मुझे राइट अपर क्वाड्रेंट पेन हो रही है, और जनरली वो पेन कब होती है, जब वो इंस्पिरेशन करता है, जब सांस वो अंदर खींचेगा तब उसको बहुत पेन होगी. तो this is the one of the important sign you can see, and it is the condition in which you can say maybe मतलब ये केस और भी complicated हो गया, that is the due to complicated PID. So ये हमारी important signs हैं. अब हम जाएंगे diagnosis के लिए. So what are the diagnostic methods? इसमें generally diagnostic methods, it can be the minimum criteria for diagnosis. There is a criteria that supports our diagnosis, and one is the definite diagnosis. So minimum criteria of diagnosis का मतलब क्या है in this case कि मतलब कुछ ऐसे सिम्टम्स जो कि पर्टिकुलरली होते ही हैं कि हमें बताने के लिए कि हाँ इस पेशेंट को PID है, दैट इज़ अ मिनिमम क्राइटेरिया. जनरली ऐसे जो पेशेंट होते हैं इनमें हम मतलब पैल्विक पेन देखते हैं, एब्डोमिनल पेन देखते हैं, सर्विकल मोशन टेंडरनेस, यूट्राइन टेंडरनेस और एडिनेक्सल टेंडरनेस देखते हैं. सो वी विल मूव टू द मिनिमम क्राइटेरिया for PID diagnosis. In this case, what you see first is pelvic or abdominal pain. Second is cervical motion, tenderness, और uterine या फिर adnexal tenderness. So this is the minimum criteria for the PID diagnosis. Now we will come to the criteria that supports our diagnosis. अब कुछ तो ऐसे symptoms होंगे जिससे हमें मतलब हम कह सकते हैं कि हाँ ये भी चीज़ इन्वॉल्व है, तो मे बी इस पेशेंट को PID हो सकती है. अभी डेफिनेटिव डायग्नोसिस पे नहीं पहुँचे हम. दिस इज द अदर क्राइटेरिया that supports our diagnosis. So what is that other criteria? Other criteria, it can be temperature. Temperature is not a definitive diagnosis. That's why it is included in the other criteria that supports the diagnosis. And there can be vaginal, cervical, mucopurulent discharge. You can, on CBC, you will see elevated WBC, ESR is elevated, and C-reactive protein. And if you do the culture, then you will see chlamydial or gonorrheal infection. So this is the other criteria that supports our diagnosis. So we will write about it. What are the other criteria? First is the temperature. Second one is the vagino-cervical mucopurulent discharge. Other is elevated WBC, elevated ESR, C-reactive protein present, and the last one is chlamydial or gonorrheal infection. So this is the main minimum criteria for PID diagnosis and other criteria that supports the diagnosis. So this is the not they are the not major criteria for the diagnosis. तो अब major criteria क्या है वो हम उसके बारे में बात करेंगे जो हमें पक्का बताता है हाँ इस पेशेंट को पक्का PID है. So what are the definitive criteria? Generally, there is three main definitive criteria for PID diagnosis. We will talk about it. Definitive criteria. First is when you do an endometrial biopsy and when you do the histological study, you can find this easily. So one of the most important criteria is histology of endometrium or in biopsy. And the second one is imaging. जब आप इमेजिंग करते हो अल्ट्रासाउंड में आपको क्या दिखेगा कि जो ओविडक्ट्स होंगी या फेलोपियन ट्यूब्स होंगी उसमें फ्लूइड होगा. सो व्हाट यू विल सी, इमेजिंग इज द सेकेंड मोस्ट डेफिनेटिव डायग्नोसिस. Imaging on ultrasound guiding, you will see tubes or oviduct, fluid filled tubes or oviduct. And the third is on the laparoscopy you will see the consistent with PID, like laparoscopic workup will show you the consistent PID. consistency with PID. So this is the main definitive criteria for PID diagnosis. So this is all about the diagnosis, the clinical signs and symptoms and definition. Now we will move to the treatment of the PID. Treatment may be, we will give outpatient treatment, it can be inpatient treatment. Like हमें कैसे पता लगेगा किसको हमें outpatient treatment देना है और किसको inpatient? So the indication for the inpatient treatment is maybe like if the female is pregnant, in that case we will give inpatient treatment. If there is any allergic, if there is a no like कोई रिस्पॉन्स नहीं है मेडिकेशन ओरल मेडिकेशंस पे, तब हम इनपेशेंट ट्रीटमेंट करेंगे. या उसको कोई एलर्जीज़ वगैरह हो रही है तब करेंगे. या पेशेंट की बहुत सीवियर कंडीशन है लाइक इन केस ऑफ ट्यूबो ओवेरियन अपसेस, इन दैट केस वी विल गो फॉर इनपेशेंट ट्रीटमेंट. सो द ट्रीटमेंट फॉर PID. Treatment of PID, it can be what? Outpatient and inpatient treatment. So inpatient हम कब करते हैं? हमने कहा जब कोई women pregnant है, pregnancy is an indication for this. No response to oral medications or complicated PID. For example, tubo-ovarian abscess. This we will discuss about it. So, अब आउटपेशेंट में हम क्या ट्रीटमेंट देंगे और इनपेशेंट में हम क्या ट्रीटमेंट देंगे, कौन कौन से ड्रग देंगे, कौन कौन से किस किस डोसेज में देंगे, वी विल डिस्कस अबाउट इट. सो आउटपेशेंट ट्रीटमेंट, जनरली कोई भी आउटपेशेंट ट्रीटमेंट होगा या तो हम IM इंजेक्शन देंगे या फिर उसको ओरल मेडिकेशन देंगे. IV कम देते हैं. So in outpatient we will give ceftriaxone IM 250 mg. This is single dose we will give, single dose. Plus what? Doxycycline 100 mg for 14 days. Per oral. This is the outpatient treatment we will give. Sometimes we add metronidazole if the patient is representing with any bacterial infection, like maybe it is anaerobic bacteria, Haemophilus influenza, or any bacteria that can cause PID. So उस केस में हम metronidazole हम add कर देते हैं. अब पढ़े हम इनपेशेंट ट्रीटमेंट के बारे में डिस्कस करेंगे. इनपेशेंट ट्रीटमेंट इज़ वेरी इंपॉर्टेंट एक्चुअली. सो इट इज़ इनपेशेंट ट्रीटमेंट. इसमें हम सिफॉक्सिटिन देंगे IV 2 ग्राम every 6 hours plus doxycycline IV 100 mg every 2 hours. डॉक्सीसाइक्लिन दोनों में देंगे, बस यहाँ पे हम सेफ्ट्रिएक्सोन देंगे आउटपेशेंट में. इन इनपेशेंट वी विल गो फॉर सेफॉक्सिटिन. इसमें डोसेज इसकी 2 ग्राम every 6 hours और डॉक्सीसाइक्लिन IV देंगे 100 mg every 2 hours. In this case we can also give penicillin if the patient is having the penicillin allergy, in that case we can give for clindamycin and gentamicin. If the patient is a penicillin allergic patient, in that case we will give clindamycin 900 mg प्लस क्या देंगे, और वी कैन गिव जेंटामाइसिन. जेंटामाइसिन हम दो तरीके, एक तो लोडिंग डोज होता है और एक होता है मैनेजमेंट. लोडिंग डोज जो है, लोडिंग डोज जनरली वी गिव 2 mg पर kg एंड मेंटेनेंस डोज जो होता है वो हम देते हैं 1.5 mg पर kg. Dose is 1.5 mg per kg. So this is about the treatment, and now we will discuss about the complicated PID cases, like it is tubo-ovarian abscess and Fitzhugh and Curtis syndrome. So what is the Fitzhugh-Curtis syndrome? In this case, we will see perihepatitis inflammation of the liver capsule and peritoneal cavity, peritoneum on the anterior right upper quadrant of the liver. So, right here, it is the perihepatitis inflammation of liver capsule and inflammation of peritoneum on anterior right upper quadrant. In Fitzhugh and Curtis syndrome, the patient's complaint is mainly वो बोलेगा कि मुझे राइट अपर क्वाड्रेंट पेन हो रही है और वो बहुत सीवियर पेन होगी. सो व्हाट इज़ द क्लिनिकल फीचर? क्लिनिकल फीचर क्या होगा उसका? That is right upper quadrant pain. अगर आप इस पेशेंट का LFT करोगे, जब आप इसका LFT करोगे तो वो नॉर्मल भी हो सकता है. जनरली LFT एलिवेटेड होता है, सारी चीज़ एलिवेटेड होगी इस केस में. सो फॉर डायग्नोसिस वी डू, डायग्नोसिस के लिए हम क्या करते हैं, लिवर फंक्शनल टेस्ट करते हैं. इट कैन बी नॉर्मल और एलिवेटेड. इस केस में जनरली जो फिट्जह्यूग एंड क्यूटिस सिंड्रोम होता है, इसमें पेरेन्काइमा ऑफ लिवर कभी इन्वॉल्व नहीं होता. जनरली ये एक अराउंड द लिवर इन्फ्लामेशन होती है. इसमें आप फाइब्रिनस एडहेजन्स देखते हैं जिसको हम वॉयलेंट स्टिंग अपीयरेंस बोलते हैं. ठीक है. सो यू विल सी वन अपीयरेंस हियर, दैट इज वॉयलेंट स्ट्रिंग adhesions. you will see here. So once more we will repeat this. Fitz-Hugh syndrome, it is a perihepatitis inflammation of the liver capsule and the inflammation of peritoneal on the anterior right upper quadrant. And the clinical feature, the patient represent with the right upper quadrant pain. Diagnosis, you will go for the liver functional test. It can be normal and or can be elevated. In this case, you will see the fibrous Voilin string adhesions. This is the one of the main complication. And now we will move to tubo-ovarian abscess. And it is one of the most important one. Generally, the treatment for tubo-ovarian abscess, if it is not ruptured, it is same as the treatment for PID. Generally, in this case, we will give inpatient treatment. So, tubo-ovarian abscess. It is a complication of PID. And the patient presentation क्या होगी इसमें? पेशेंट बोलेगा मुझे राइट अपर क्वाड्रेंट पेन या राइट अपर क्वाड्रेंट पेन होगी, एब्डोमिनल टेंडरनेस हो सकती है या पेल्विक टेंडरनेस हो सकती है, उसको बैक पेन हो सकती है, रेक्टल पेन हो सकती है, फीवर, चिल्स. दिस इज़ द मेन tubo-ovarian abscess complications or presentation of the patient. What? Pelvic or abdominal tenderness, other is fever or plus chills and back pain and rectal pain. Now, if this abscess ruptures, it can lead to very severe complications. You can see the peritoneal signs, that is Blumberg sign. In this case, you will see the rigidity, you will see rebound tenderness, and you will see quarting. When you palpate and patient he is having severe pain, so that's why patient guard himself. And in this case, you may see. So what you will see if the tubo-ovarian abscess rupture, what you see? You will see